and welcome to this episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name is Kat Ralston. I'm a member of the TNMC and a geriatric medicine registrar in Edinburgh. And today I'm delighted to be joined by Professor Miriam Johnson to talk about palliative care in heart failure. Miriam is a Professor of Palliative Care and Associate Director of the Wolfson Palliative Care Research Centre at the University of Hull, and she set up one of the UK's first integrated palliative care heart failure services in Scarborough. Welcome, Miriam.
Hello, nice to be here.
Thanks so much for coming on the podcast. So I think we're going to talk about this in two parts. So first of all, thinking about the why of palliative care in heart failure and what services could and should look like. And then getting a little bit of the nitty-gritty around symptoms and assessment and conversations around a person with heart failure with the mindset of palliative care. So first of all, I'd just like to start by thinking about why palliative care is important in this patient group and maybe bringing in some of the evidence that supports that for people with heart failure.
So yes, it's something that really people have got to grips with over the last 20, 30 years, but it still seems to be a bit of a surprise to some people just how symptomatic, how needy some of the patients are. I think because heart failure is one of those great success stories, isn't it, where the triple therapy in the early days made such a difference, and ongoing treatments and new devices, and people really can go from being seriously, seriously ill to living very fulfilling, high-quality lives. And maybe we've been lulled into a sense of security, false sense of security, that therefore the job is done. But it means that we now have more and more people surviving some of these events and living with heart failure for longer. And in time, they do run into trouble. And of course, they can run into trouble intermittently so that it adds that degree of uncertainty, which people often talk about. But the clear evidence is that these people are symptomatic. They can have poor quality of life. They subject to high admission rates in the last year of their life, often actually due to comorbidities rather than the heart failure themselves, because the heart failure often coexists with many other conditions, particularly, for example, other smoking-related conditions like COPD or degenerative conditions like arthritis, all of which deeply impinge their ability to live independently in the community. They also have less access to supportive and palliative care services. I mean, for example, nationally, looking at the time from referral to specialist palliative care services to death, for people with heart failure, it's something like 6 days. Under anybody's definition, that's a bit maybe too little, too late. And when it comes to thinking about evidence as to whether specialist palliative care can help improve people's quality of life and emotional functioning, a meta-regression we published just this last year of 39 trials in palliative care, of which a significant number were in organ failures. It showed that actually people with non-cancer conditions did very well with specialist palliative care. Now, partly that might be because they have less baseline access to integrated supportive care than people with cancer do. But nevertheless, the evidence is there that this helps. But the key take-home message from this big meta-regression is that the higher effect sizes were in people who'd had access to palliative care for at least 3 months. Well, if these patients are only getting it for 6 days before they die, well, that's a bit tricky, isn't it, really? So they're very needy. They don't get the care they should. Neither do they get the level of understanding that, say, people with cancer do. Often they've got this idea there's another rabbit that the clinicians can pull out of the hat and they'll be right as rain again, that the treatments that they're on that have always helped will always continue to help. And consequently then, they're less likely to be involved in advanced care planning, less likely to be involved in end-of-life decision-making, more likely to have invasive, more futile treatments. So actually the need in this patient group is very significant. The best way of tackling it is something that we can talk about.
I mean, the numbers are stark, aren't they? That seems terrible that 6 days before death is
That's the median, of course, obviously. But that means that there's some people even worse than that. And of course, many people actually don't get it at all when they should do.
Yeah, and for a group that, like you say, is going to have a high symptom burden and this sort of inequity of access for non-cancer conditions, it feels really important. So thanks for sharing some of the evidence around that. And I think, like you said, it's a condition with some really good disease-modifying therapies now. People are living longer with it, and identifying who might benefit from palliative care, you're talking about this 3 months or over to have benefit, can be a bit tricky, I'm assuming, because that's why people aren't getting to the right services. So what advice would you have about how to identify the patients who might benefit from palliative care and the timing of that?
Well, this is where I think we've been so caught up with prognosis. It's not just clinicians, it's the whole of society. Are so fixated at avoiding death at all costs that when we try to do things based on "are we there yet?" I'm waving my fingers around in quotation marks, it just leads us down the wrong path. I mean, even in the old days when cancer treatments, you had one line of treatment and then that was it, and then you fell off the edge of a cliff. Maybe even in cancer care, that might have been a reasonable approach to say, right, okay, let's now involve the palliative care people. But even in cancer, it doesn't work like that now. There are multiple lines of treatments. There are multiple approaches. The path is often one of deterioration and partial recovery and deterioration and partial recovery. And we're learning in cancer to say, well, what is the problems for the patient today and who is best to deal with it? And that is exactly the approach we should be using for people with heart failure. It's not so much as are we there yet, as what are the difficulties this patient is experiencing today and what is important to them. So, for example, there was a really nice cohort study done by the Glasgow team led by Ross Campbell, where he followed a group of people who were admitted to hospital with heart failure, did a really good forensic description of their symptom burden, their other issues, and then followed them up over time. And one of the startling things was that 27% of them had serious or persistent symptoms that may well have benefit from being referred to specialist palliative care, but only a quarter of them had any involvement with specialist palliative care teams. Why? Because nobody is doing that level of assessment. They often don't know that the patient is having these issues. So unless we assess and ask, and that's to say nothing of the raft of moderately bad symptoms that really should be being picked up and dealt with by the usual care team, it's often people just don't know. And we know that if you don't have a systematic approach with patients, we then put the onus on them to have some kind of magic knowledge as to what is important to bring to a clinician, what is legitimate to bring to a busy doctor that they see. We're all run off our feet. We've only got time. And particularly in the primary care setting, they very definitely got the message. It's one problem, one consultation. And again, these are people who are comorbid. They have multiple problems. And they prioritize and only present the one thing which is absolutely killing them that day. Whereas if you ask, you unmask a whole pile of other things. There was another interesting study done of patients referred to palliative care service where they asked for initially a volunteer your symptoms, an open question, what's troubling you? On average, one problem was volunteered by the patient. When they then used a systematic approach to follow that, it came up with an average of 10. Now, these weren't tiddly little things. These were problems that the patient rated as severe and distressing, but the patient will not necessarily routinely tell you. So someone in the team, somewhere embedded into the service, needs to be assessing what difficulties the patient is experiencing today and not forgetting that that person is surrounded by family and friends.
Yeah, that's so interesting about that volunteering versus a systematic approach. But I'm not surprised by that, just because I feel like that often happens in our geriatric medicine clinics as well, that once you start delving down, lots of things are coming up. But I think that's important for people to remember, that actually when patients feel like they can only bring one problem, then that's probably what they're going to do. And I think from what I'm hearing is that this "are we there yet" sort of mindset means that if we're there, it's probably too late actually. And everyone needs to be assessing a patient's needs. And if they've got needs that would be helped by a palliative care assessment, then that is the right time to get them involved. Would that be fair?
Indeed. And in fact, I think this approach also sorts out two problems at the same time, because the second problem is that clinicians, because we're human beings, find it really difficult to say hard things to patients. And again, where you've got this long clinical relationship where the clinician has always been able to, as I say, pull the rabbit out of the hat, it's so hard. It must be really difficult for that clinician to have this patient with these trusting big eyes, assuming and expecting that they're going to be able to rescue a situation, to then have the conversation of, actually, this is where we're at. Now, if you want to involve specialist palliative care at that stage, you're equating specialist palliative care with "you're dying now." So the conversation becomes "you're dying now." That really ups the ante in that conversation. And no wonder clinicians avoid it until they really can't avoid it any longer. Whereas if you've already had the conversation of, right, well, what I'm hearing is that your breathing's really terrible today, and you've also got some worries about how you're managing financially at home, and I can see that, I'm hearing that your family are finding it really hard. Well, what we do in this situation is that we involve our palliative care colleagues. or Dr. whoever, or call them whatever you want. I really, really don't care. Just, this is how we do it here. You normalize it and say, we would really like you to go and see them. That's what they do. They'll assess, they'll give us some advice maybe for us to do, or it might be something that they would do to address this particular problem in the here and now. And once they've met this lovely palliative care team, when things do deteriorate and you're becoming close to death, that conversation is so much easier. Well, I think really we should involve Dr. So-and-so again. Oh, yes, I remember seeing them last year. They were very nice. I loved it. And I'd love to go back there again, or whatever. So you take the sting out of that second conversation. The corollary of this is that over time, palliative care services have had to get their act together a little bit. And when they were set up, because it was set up very much for the last weeks and months of life, it really was till death do us part. And now we're dealing with a more chronic disease model. They're really having to, I can say this having been in palliative care, get over ourselves and recognise that actually we go in, we do our bit like a hit squad, and then we back off again. And then we come back in again, and then we come off again. There's a kind of a revolving door rather than a one-way ticket. And that helps then deal with the worries that the specialist palliative care team had of being flooded by the enormous need that's out there. They don't have to solve the world. It's neither necessary nor sustainable. I found in my now getting to be long in the tooth existence clinically is that actually I've never yet met a doctor or a nurse who's not there because they don't want to help patients, want to have a good relationship with their patients. They might need a bit of support. They might need a bit of training. They might need a bit of encouragement to get there in terms of holistic assessment and symptom management, etc. But it's not rocket science. And actually, the vast majority of it is everybody's job, supported by the specialist team, as in any branch of medicine. So, I do find it a bit kind of odd that we've got ourselves in such a pickle about this, really. It's about the assessment and appropriate use of resources according to your local teams.
Yeah, I think that's right. And that expectation setting and normalisation of seeing specialist palliative care services also feels really important. So it's not sort of this big conversation that feels very scary. So I think that's a really good point to remind us of.
And in fact, the evidence is really coming out in support of this. Just last month, we're in December. In October, another trial published where they looked more upstream with earlier stage heart failure, and they randomized to having really excellent usual care, actually. And, this is sometimes you think usual care makes you laugh in these trials because you think that's not usual care where I work. Fabulous resource with excellent optimization of the treatment, 3 monthly follow-up appointments with the specialist, and heart failure nurses falling out their ears. And I'm thinking, wouldn't that be lovely? But nevertheless, this trial just published, I think it's Balata, shows, very little added benefit from the patients allocated to the additional specialist palliative care arm, apart from things like spiritual domain, where there was clearly a value add. And, they were saying, this is about identifying which patients need specialist palliative care. It's based on need, not just because they've got a diagnosis of heart failure. And we need to be really clear about this. Specialist palliative care services are there to enhance the usual care services for people with persistent, serious symptoms, complex family dynamics where you need that additional bit of time with people who are going to really able to start to unpick what's going on, that social support, that spiritual support. These are the sorts of things, is being really clear about what the value add for specialist palliative care is and when you need to involve the additional team. But that predicates on the usual care team being able to assess, not being scared to do a holistic assessment, not being scared to go there with psychological symptoms, not being scared to ask about future fears and concerns because they're afraid of a Pandora's box and they don't know what they're going to be able to get. And the waiting list is already halfway out the door and they don't have time and all the things that are real difficult, genuine challenges for usual care teams.
Yeah, absolutely. And it kind of just looks like what you have available to you at the time and what the patient's needs are, and then working out what service is going to be best placed to help them. And we've sort of touched on this a little bit through our conversation, but I wonder what you think sort of good specialist palliative care services in heart failure look like in terms of who should be involved. We talked a little bit about access, and I think you've done a lot of work into integration with sort of cardiology services and things. Can you speak a bit more to that?
I strongly recommend, if you read nothing else as a result of this podcast, to read Tracy McConnell's excellent realist review, where she really does start to unpick where heart failure services benefit from palliative care services. Where does it work best? How and what are the things that make it happen? Because that's it on the ground, isn't it? It's in every single clinical guideline that there should be integration with palliative care. Everyone agrees, even on the sort of slightly mixed evidence base from your standard clinical trials. I think there's very few people who really seriously in their heart of hearts doesn't feel that palliative care somewhere in some shape or form for heart failure patients isn't a good thing. But how do you make it happen on the ground? And her review talks about, things like the capability. What helps this happen? What motivates people to make this happen, to work together? What opportunities help make things to work together? And what are the sort of behaviors that really make this happen? So if we start at the behaviors, she talks about how important it is at the commissioning and organizational level that palliative care and heart failure integration is prioritized. You can get a long way with enthusiasts on the ground, where you've got good relationships between palliative care people and cardiology people. And that does happen, and you can get a long way with that. In fact, when we started our service, that's exactly how it happened. The difficulty with that is it then depends on individuals, the enthusiasts, and all it needs is for one person to move on and the whole pack of cards can come down. Unless this is embedded at recognizing the importance of this at the resource and organizational level, it is difficult to sustain and embed. You need the collaborative working between and across disciplines and settings. And this is where I think one of the things fall down is that you can get cardiologists and palliative care people to work together. It usually starts within the hospital, with the hospital palliative care team working with the cardiologist, but working to involve the local hospice, which is often off-site, but also primary care, because they're the people who are often the first stop. And if there's joined up thinking across all three settings, that really, really helps embed this service. Heart failure clinicians really need to involve palliative care on the basis of need, which we've talked about. And there needs to be early discussion between heart failure and palliative care. One of the most useful things I think I contributed to the MDT we had was putting my hand up saying, does this patient know about their ICD and how long that's likely to be helpful for? Excuse me, this person's coming up to have their battery redone. Has anyone had that conversation? Excuse me, that was my job excuse me, has anyone had that conversation? It's almost a bit like a Jiminy Cricket on the shoulder of saying, hang on a minute, let's just take a step back and review what's going on here. The other thing she identified was, the increasing awareness and seeing the benefits of palliative care and those influential champions are not to be sniffed at. Once clinicians on the ground start to see, firstly, that the palliative care team have not undermined the relationship between the cardiologist and the patient, when they've seen that the palliative care people haven't just undone everything that they've just been doing for the last 10 years, and they start to see the patient pick up and living better, then they're way more likely to refer the next patient. Opportunities, you need protected time for and choice of training. There often needs to be a service reconfiguration. For example, Karen Hogg's Better Together service up in Glasgow, she's a cardiologist, reconfigured her week so she had one clinic dedicated to people with advanced disease with slightly longer time slots. So some of these issues could be worked together, and worked very closely with nurse consultant Yvonne Millerick, who then did a lot of the cross-setting stuff. So thinking how those services are configured, MDT working to build relationship, opportunities for shared learning and developing common goals, having easily visible and accessible and prioritized guidelines that are put into practice. And she articulates this so beautifully in her paper, and I really would recommend that you read it and have a look at it, because it's done very well.
Yeah, and we'll put a link to that paper and other ones we've mentioned in the show notes for the listeners to have a look at. But that's really interesting. It all makes complete sense, but I think having it written down is helpful when we're thinking about services and service design. Okay, so we'll move on a little bit to the more practical points with the patient in front of you. So we'll maybe think about assessment first. So we've talked a bit about this needs assessment. So what does that patient who's sitting in front of you need today? Any sort of further thoughts on how we approach the assessment of a patient with heart failure from a palliative care mindset?
So I would say this is where it depends on your experience and level of confidence. So working with some very, very experienced heart failure nurses, for example, they're already doing a holistic assessment, and it's kind of there in the patter, if you like, that they worked up over the years. But I would say they're quite unusual, and most of us, at least to start with, can benefit from having some kind of prompt framework. And I'm not talking about something you read out. How are you feeling with this today? How is your this, that, and the other? No, it's very much the conversation, but a prompt to say, have I explored all these different domains? Have I explored physical symptoms, impact on daily life, psychological concerns, social concerns, fears for the future, existential concerns, legal stuff? And also then there's that kind of gut thing of, is this patient in a family where it's going to make things really difficult to manage them over time? And we all know who we're thinking when I say that, in clinical practice. But it's, unless you specifically think about it and clock it, sometimes it can kind of come up and blow up in your face, whereas you can spot them coming. There's going to be difficulties here. They're going to need a lot of extra support. This family have had an awful time, or there is no family, or, you kind of see them up front. So why not clock it systematically? And then it's about, okay, of these issues, I can do this one, this one, this one. I can refer that one to other people in my team. But that one I'm really stuck with. And actually, I really think an early referral to the clinical psychologist, if of course you have such a rare beast as a clinical psychologist, I think actually we should talk about that now. Or actually, I can see that there's going to be so many different things. It will be better to send to the specialist palliative care team where they have all these aspects addressed in a one-stop shop. Or it might be, actually, this patient hasn't seen their geriatric team for ages. I really need to get the geriatricians to do a bit of a whole person review with them. Now, that would be novel, to have the cardiologist referring the patient back to the geriatrician. I'm not quite sure how often that would happen. Or working closer with the geriatricians as well. Or even contacting the GP and say, look, this is what we've done. This is where we're at. Could you take this conversation forward with them? It's about clocking the profile of concerns and then triage actioning how each of them are dealt with. Now, the only tool that particularly does that is the needs assessment tool in heart failure, but it's not something you can just pick off the shelf and just implement. And we've been able to pretty much do this in primary care for a cancer version and in oncology because a lot of their training is around holistic assessment. I think in cardiology clinics, I suspect in geriatrics you might be able to do it as well, actually. But, don't just assume you can pick something up and then plop it into practice and everything's going to be hunky-dory. There are implementation issues that really need to be considered. And also people are worried about what if they tell me something and there is no service to refer them to? Well, we know from what patients tell us that firstly, they love being seen as a whole person rather than a bit of them. Secondly, they don't expect us to fix everything. But you know what? They really, really appreciate somebody hearing and acknowledging that that's difficult for them. And we forget the therapeutic power of clinical presence. I don't know why we do that, because we do know it, but then we forget it the minute we're with a patient. So there are some needs assessment tools. There are also patient-completed tools that you can use in this space. So there's a heart failure version of the IPOS, which is the Integrated Patient Outcome Scale, which is an interesting one. It looks at the level of concern. So it's not quite the same as a quality of life tool, which just talks about how bad is this, or can you do that? It's how much bother is this causing you? How much concern do you have? And it's interesting to see you can shift the severity of that by simply the patient feeling they've been listened to and they've got a plan of how they're going to deal with it. And the it doesn't necessarily have to go away or even get enormously better for the patient to feel better, that they've got more control over what's happening and their level of concern comes down. So the IPOS heart failure is another one that is a possibility. Again, how you implement it into practice is a completely different kettle of fish. And I think that's one of the areas that we need to be working at next, particularly in health services where you've got fee for item, with devices going in. Where is your organizational resource going to go into? It's going to be getting in as many as possible. It's the huge pressures on services. How are you going to, I mentioned about reconfiguring services. Having that courage and confidence to step back from the top down and say, look, actually, we're not doing our patients the best service here. I go back to the recent trial of early integration, the one just published in October, early integration. Interesting, both groups, they improved quite significantly. Good care really helps patients and we should be doing it. But we get caught up with the pressures and complexities of a constrained health service. But that shouldn't stop us looking to see what can we do within current resources and pushing for better.
Yeah, absolutely. And I think that we forget that just being heard is really important. for patients. I think you're absolutely right that people worry that patients might bring up something that they don't have access to a psychologist or whatever, but actually that's really important. They're just listening actually do quite a lot. And I think there's definitely parallels with that holistic needs assessment with comprehensive geriatric assessment. And I feel like there's a bit of a Venn diagram between cardiology, palliative care and geriatric medicine here, isn't there? And, it just really depends on what services you have in your area and how things are set up. But there's lots of people that are able to help with patients who, have needs that need to be met. And our hospital home services deal with a lot of patients with heart failure as well. So it feels like we're all hopefully we're working towards the same goal.
Yeah, and I'd add primary care.
Of course, primary care, extremely important, and the community services. So, yeah, thanks very much for that. And patients with heart failure can experience a lot of different symptoms, and we don't have time to go through them all. And we can link in the show notes to helpful guidelines that could help you when you are seeing patients with symptoms. But I wondered whether we might focus on breathlessness and just talk through that as a very common symptom in patients with heart failure. Would that be okay?
Yeah. And, as you know, breathlessness is one of the symptoms that I've spent many years researching to try and find solutions for people. And it's been a very interesting thing to observe that in terms of conducting trials and studies which are symptom-based, it's actually been quite hard. And it's not just me that says this. There's a very interesting editorial to our morphine trial that we published. Very interesting editorial commenting on how hard it was to engage the heart failure community in symptom-based research. Again, I think part of this, it's such an exciting area of disease modification research in heart failure. I can completely understand it, but yet the symptom burden of patients is significant and surely deserves a really good go at trying to find out how we can best improve them. So a lot of the intervention research, evidence base for interventions, actually has very little representation from heart failure patients in it. So we are extrapolating. However, what we understand from at least the central perception of breathlessness is that the mechanisms seem to be a final common pathway. So although there will be slightly different peripheral mechanisms contributing to the perception of breathlessness, many of the techniques that we have an evidence base for, there's no reason why they shouldn't be helpful in people with heart failure. And I think clinically, obviously I would love to get the research evidence for it, story of my life. But I don't see there's any reason why we couldn't, in principle, apply therapeutically to the heart failure population. And I would say the first thing is obviously optimizing the disease modification treatments. But then it's the non-pharmacological interventions. And I do think that as doctors, we are appalling at recognizing the benefit of our non-medical colleagues. And we give a lot of lip service to the physios or the OTs. How many times on a ward round have you just heard the casual, for OTPT, and you think, do they really know what they're even asking for? For those listening, I can see Kat smiling because we know exactly what we mean. And I certainly know from my allied health professionals, it's a common moan that, doctors have no idea what we do. They have absolutely no idea what benefits we can make. Now, in cardiology, you've got no excuse because you have a proven fabulous non-pharmacological intervention called cardiac rehab. We also know that heart failure patients do not get the access to cardiac rehab at the level at which they should. It's very poorly taken up, very poorly accessed. And that's not just in the UK, that's across the whole of Europe. Now, part of that problem is resource. Part of it is because it's just simply not peddled enough. And it's not prescribed enough with the force of this is as important as your tablets or your whatever. But also it's because we do not address the issue of breathlessness. Now, I don't know if any of you listening have been seriously breathless at any point. It is one of the most frightening, scary, awful experiences you can possibly have. And even if it's just that you have to stop and recover every 2 or 3 steps going up the stairs, it needn't be the frightening level, but it's still a blimmin' nuisance and a real unpleasant thing in your life. And I cannot blame the many, many patients for whom their response to that is, that was awful, I'm not doing that again. And the response is avoidance of the physical activity that made that happen. And don't forget, emotional exertion also increases breathlessness. So physical and emotional exertion will increase breathlessness. So if you've got that patient who is breathless every time you get them to move and you say cheerily, and I want you to attend cardiac rehab. Oh, what's that? Oh, well, they'll put you on an exercise bike. Yeah, right. No wonder people with more moderate to severe breathlessness are those much less likely to even start going to rehab, let alone complete it. So if we do not give them some management tips and techniques to manage their breathlessness right at the get-go, we're not going to get them to cardiac rehab, even if we're being good boys and girls and are sending them off to them. And we actually have a local organisation that has enough resource to cope with people who are heart failure in addition to ischemic heart disease. So getting in cahoots with your local physiotherapist, or often nurses have learned how to do these skills. And actually, there's no reason why doctors can't either. As I say, it's not rocket science. And there's very simple things that you can get into, as I say, your spiel when you're talking with patients. And the first thing is to identify it. And the thing is that if you say to a patient who's sat with you in clinic and who's been sat in your waiting room so long that they've solidified, they're not going to look breathless. So you cannot depend on, well, do they look breathless? No. And even if you say, are you feeling breathless? They'll often say no, because they've stopped doing all the things that make them feel breathless. So you do need to delve a little bit and say, okay, well, what are you able to do before your breathing stops you? Otherwise, you're just not going to get that kind of idea. I think in geriatrics, you kind of pick that up through ADLs, but it's still, I would say, even working with some of the best geriatricians I know, there's still picking up that someone is breathless is actually not as straightforward as you think it might be, and it's easily overlooked. The first thing is to find it. And then the second thing is to then just start to get them to understand how it works. And there is a very useful clinical framework called the Breathing, Thinking, Functioning Framework, which was developed by a fabulous team down in Cambridge, multidisciplinary team. And it is one of the things that was so useful in my clinical practice, and patients just got it. It's like 3 aggravating circles that feed into a central circle of breathlessness. So on one side, you've got breathing. So we know that when people get breathless, they often develop inefficient breathing patterns. On the other side, you've got thinking, and I would also put emotion in there. So what's going through somebody's head can really build up that breathlessness. And we also know from our basic science work, from our neuroimaging work, that our brains are so clever, our brains predict the symptom and generate the symptom based on previous experience. So if we've had a bad experience of pain or breathlessness, and we think we're heading into that situation again, we will be feeling it before it's even there. So understanding that and getting the patient to understand that is really crucial. And the last circle is functioning. And we've talked about it a little bit, haven't we, about this deconditioning cycle of avoidance of physical activity. And then it has this knock-on effect. It really cramps their social space. I can remember one patient, we were talking about, all right, well, what would your goals of breathing better? He said, I want to be able to get to the bus stop down the road, because once I get to the bus stop, I can get into town and I can meet my mates in the pub. And that, we managed to get into the bus stop through doing these breathing exercises. And that was the outcome. That was the win for him, because his functioning avoidance cycle had so restricted his social space. And that was then affecting his levels of depression, etc., etc. So in the resources, we'll point you to the Breathing, Thinking, Functioning clinical framework. And, you can go on training courses. This is straightforward stuff and anybody can learn how to do it. And I would say somebody in your team needs to know how to do this. And every patient who is breathless needs to do this. And I'll say particularly to the geriatricians, once patients are starting to get frail, you're really talking about a high prevalence of this sort of persistent breathlessness. One of our PhD students, Helen Elliott Button, did a beautiful cohort study and showed that it was pretty much 40% of community-dwelling elders at risk of frailty had persistent breathlessness. And yet only 10% of them had anything done about it. It's a big unmet need because it flies under the radar, because you look normal when you're sat there. If you're breathless at rest, you're really seriously ill, actually. Most people are just living with this debilitation. And we know that it gives a lot of disability. Again, lots of population-level observational studies showing strong relationship between breathlessness and disability. So getting them into the non-pharmacological techniques, breathing techniques, cool air across the face with the handheld fan. We know that this modulates the central perception of breathlessness. It's not just a distraction. It's not just some fancy gimmick. We also know that you need a certain flow rate. You need at least, I think it's about 2.85 meters per second. We demonstrated that there was an optimum speed to improve recovery from exertion-induced breathlessness. So it's not just a oh, there, pat them on the head, give them something, is actually got a scientific basis behind it. In my clinic, I used to just very simply getting them starting to do sit to stands as a way of getting those big glutes and quads muscles to be a little bit more functional. I distinctly remember one lady, she could just about get out of the chair. And the next month she came back in and she stopped at the clinic door. She said, before you say anything, she says, I have something to show you. And she strode into the room, sat into the chair and whizzed up and down 5 times, looking very smug with herself. And she said, it's really transformed my life because I told her to do it every 2 hours. And she was the sort of person who would do that. That's the other thing, I guess, is with these non-pharmacological stuff, we're into the really difficult box of self-management. And we kid ourselves if we think we've done our bit by saying, you need to do this, 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 this. There's a whole context to this. If you're dealing with somebody who has got all the socioeconomic determinants of poor health, their ability to engage with self-management techniques is likely to be really difficult. And they're going to need an awful lot more support and understanding before they will work with you on that. And that is not their fault. It is our fault as clinicians for not spotting that and nuancing our treatment to the individual. And particularly people who are breathless, we are dealing with a lot of people who have those socioeconomic determinants of ill health because breathlessness is a marker of that by and large. That's the non-pharmacological side of things.
Yeah, I think it's really important to have a reminder of the evidence base and the importance behind non-pharmacological techniques for breathlessness. So thanks for sharing that. And I suppose we as clinicians often like to give things as well.
Love to prescribe stuff, yeah.
Maybe sort of touch upon opioids, benzodiazepines and what their role is.
Well, opioids, again, the vast majority of the literature that we have, well, there's poor representation of heart failure in this. There are some, but it's mixed. And in the respiratory world, there's more. And what we have is that in the laboratory, so in laboratory-controlled conditions in the exercise lab, where you really can measure exercise endurance and do ISO load. So what's the breathlessness level at a particular load or a particular time with a particular load? We know that opioids improve both exercise endurance and breathlessness perception. The difficulty, we also know actually that the breathlessness perception pathways in the brain is absolutely littered with opioid receptors. So it makes sense that, it must be doing something. We know that if you give endogenous opioid inhibitors, that people's exercise-induced breathlessness is worsened. We know from functional MRI scanning that if you give opioids, it can modify the central perception pathways of breathlessness. So we know that they do something. The difficulty we've had is that when you take those trials into real life, into an ambulant population, where you have this complexity of exercise-induced breathlessness, but you don't have an ISO time or an ISO load breathlessness measure, it becomes very difficult, if impossible, to demonstrate an improvement in the breathlessness sensation. So what we have is resoundingly negative parallel group trials of breathlessness, except signals for the more severe breathless group. And there's one trial by Abernethy where patients had to be breathless at rest, and that was a positive trial. So again, where you're getting the exercise component out of it. And by ISO time, ISO load, let me just give an example to help people get this point. So my dear husband entered me for the Great North Run. It's a half marathon. But I thought I'd better try because he thought it was a good idea. Anyway, first day I went out, I ran 100 meters. I got 10 out of 10 breathlessness, thought I was going to die and stopped. However, a month later, yes, I got 10 out of 10 breathlessness, thought I was going to die and had to stop, but I'd run a mile. If you just said, does exercising help breathlessness? You'd say no, because the breathlessness score would have stayed the same. But my exercise endurance had gone up. So the problems we have with our current pragmatic trials is that they don't have a standard exercise kind of modification factor for it, if you like. However, there are 2 that have looked at physical activity. So the Beams trial, which was published in JAMA, and they didn't have space for this particular aspect of it, but the exploratory data about levels of physical activity was published in the European Respiratory Journal, and that showed that everyone in the opioid group had increased levels of physical activity. Well, all the opioid groups, not everyone did, obviously, if you averaged them over. And our recent Mabel trial, which we've just presented at the British Thoracic Society, shows a similar finding, that in the secondary outcome, no difference in the breathlessness outcome, but in the physical activity level, In fact, there was an average of 10 minutes more a day of moderate to vigorous exercise in the opioid group. So, it's not a clear-cut data evidence base. And as I say, it's poorly represented with heart failure patients. But as we seem to think that this is a central modification, this is likely to be a final common pathway. I would say, where are we at now? I would say, well, if you're going to try it, firstly, you've got to be careful about renal function because heart failure patients' renal function pops up and down like a yo-yo. So I'd have quite a conservative EGFR to give them a bit of leeway. I would say at least over 30 to allow for those fluctuations so that you don't get morphine accumulation. I would say you have an agreed endpoint that relates to function. So my example of the man at the bus stop. Does it help you get to the bus stop? Does it help you get up the stairs without having to stop 5 times? These are the sorts of things rather than does it make you feel less breathless. One of the other things that we've shown in the recent trial is that you have to have early identification, monitoring and management of known morphine side effects, constipation, nausea, vomiting. But what we did show was that the doses we use, there was no difference in cognitive function, there was no difference in sedation or daytime sleepiness, the sorts of things that people worry about. We also didn't show any evidence of respiratory depression. Low dose, well monitored. We know the side effects of morphine. It's been around since, Adam, back at the creation of time practically. So we know what to expect. We know how we should monitor and care for patients. But the evidence base is not clear. However, with some antidepressants, there's been some basic science that says serotonin should be involved in breathlessness. But there's been a phase 3 trial in sertraline and now recently published phase 3 trial in mirtazapine, again in respiratory disease. But again, if this is a central effect, it's applicable, at least I think. Resoundingly no benefit. And in fact, in the mirtazapine trial, a signal of harm in the mirtazapine arm. So, I come back to saying the non-pharmacological is the mainstay. The opioids are for when you've got everything else absolutely optimized and the patient's still in trouble. And then you monitor really carefully. You co-prescribe a laxative. You review them closely. And if it's not making a benefit to their function, you stop it. In terms of benzodiazepines, I would say I would always try very hard to go for psychological approaches to panic. There are very, very few patients where I would say you've got to go for a very short-acting benzodiazepine. And you're really into the land of clinical gut feeling here. The evidence base is very poor. It's just not there. So you're going on common sense. Right in the last few days of life, if you've got somebody with totally resistant breathlessness that is overwhelming and sedation so that they're unaware while they die, then obviously benzodiazepines would have a place as part of your sedative regime. But that's very clear what you're doing and why, and you're not sedating to death, you're sedating while they die as the only option to manage that control, and done in conjunction with the conversation with the patient of this is what we could do, is that acceptable to you, and make it really clear to the patients, the families, what you're doing, or that comes back to bite you.
Yeah, that's really helpful. So I think just really focus on non-pharmacological techniques as your first line, and also optimizing the disease if you can with diuretics and disease-modifying therapy. And then you can go on to opioids, probably a slightly better evidence based on something like benzodiazepines in a sort of controlled, monitored, see if it helps, stop it if it doesn't.
And I would also use low dose and I would use sustained release. If you send someone away with a bottle of Oromorph and say, take some of this when you need it, how's the patient supposed to know what level of need you take it? And I think particularly with the fast-acting transmucosal fentanyls, there's a very telling case study published by Daisy Janssen where they had a patient who was on 10 BD of MST and someone had given them fentanyl nasal spray for PRN episodes. And she came in, she was taking something like 40 a day. If they had, a dreadful time with withdrawal, and it was anxiety and needed psychological approaches to sort that out. And it took 6 weeks to deal with that. Beware the quick fix. Yeah. It is not a quick fix. If someone has got significant anxiety, they need significant anxiety interventions, not just a sticking plaster.
Yeah, that's a really good point. Okay, yeah, that's a really helpful overview of breathlessness. And we might just finish up with any top tips. We've talked a lot about shared decision making and touched on advanced care planning or future care planning conversations. Do you have any sort of top tips for people approaching these conversations?
I guess it's a bit of a call to senior staff. Don't underestimate how you model the service provided by your team. An interesting paper coming out with one of our academic foundation doctors did a beautiful series of interviews about CPR conversations in heart failure. And one of the most striking things that came out is if the first experience of that type of conversation with a patient was a bad one for the clinician, they avoided it like the plague. And often that first experience is a junior doctor witnessing a senior doctor doing it. So I would say, if you get really good communication skills training, it's never too late to go and do some serious advanced communication skills, or sitting with someone who you admire, watch what they do, really take the time to do it well, because that's at the heart and the root. In fact, you only have to go and look at your own hospital's complaint register to know that the vast majority of them, the underpinning issue was poor communication. And this is all about joint decision-making right from the get-go. It's about psychological support. It's about realizing why this person's breathlessness is refractory. It's because they're worried out their brain. And nobody's really kind of unpacked that. So get good at communicating. And instead of using uncertainty as a reason to avoid these conversations, if there's uncertainty, surely that should be a trigger for these conversations, because something bad might happen. And why wait until it does, when no one's in a fit state to be able to think about anything? So I think that would be my thing, is communicate, and relationship. Get to know your pally Ps. They're usually quite nice, but teamwork and communication, I think.
Absolutely. And I think that also would extend to, thinking about disease modifying or existing therapies that a patient might be on, like sort of the devices and their long-term medications, things like that. It feels like that's all going to be sort of shared decisions between you, the patient, and cardiology services and whoever else might be involved. Is that fair?
Yeah, absolutely. And don't forget to keep the GP in the loop.
Yeah, absolutely.
And particularly, if the patient comes and tells you, well, my GP's told me that we could maybe stop this now, the last thing you do is say, oh, we're not at that stage yet, and undermine the GP. Why not go back to the GP and say, oh, that was interesting. Have you seen something I haven't? Let's talk about this. Because the GP might just have spotted a deterioration in the context of knowledge of the family that you haven't.
Absolutely. So important, because they probably know the patient, and the family in much more detail than you will. Yeah. Thank you so much. That's been such an interesting conversation. And I wonder if you've got any take-home messages that you'd like anyone listening to maybe take forward into their practice.
I think it's about get to know the team, involve the team, learn how to communicate really well and practice it with your patients, and identify what's going on for them. Find out what the problems are, figure out who the best person is to deal with it, and acknowledge if there isn't anything else that can be done about it. And often that is a gateway for really useful conversations, apart from anything else. So somebody in the team's got to be able to do it, and then get to know your friendly pally care people to help out when you're getting stuck or need a bit of extra help.
Great. Well, thanks so much for speaking to me. That was excellent. I've learned a lot through the conversation, and I hope the listeners have too.
Thank you for inviting me.
The TNMC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.